Good afternoon, ladies and gentlemen. So first of all, I'd like to thanks to Milton has already inviting me to these very prestigious meetings. So I'm going to talk in the last sessions and last topics regarding the poor responder, especially for the digital mobile applications that we call it the Indonesian Kalkulator of Oocytes. It was launched 1 year ago just to help the gynecologists whenever they want to do control ovarian stimulation, and also helping the patients to know their biological age through the serum image examinations. So I think we all agree that if we found our poor responder patients sometimes are frustrating, but sometimes also very challenging. So outline of my talk is a bit about the case illustrations. Who is poor responder patients? How do we treat our patients? And then the last is the decision making on poor responder patients. For the first case, this is a lady 38 years old with suffering from primary infertility for 15 years with very low MS level 0.01 nanogram per milliliter, with number of IFC only 200 follicles. The sperm analysis revealed severe oligozoospermia with a bit higher of DNA fragmentation index. And the next planning, what are we going to do for these patients? We are going to start stimulation immediately, or giving oral supplementation androgen for 3 months, or asking to Milton. But we decided to starting stimulation with high dose gonadotropins. We start with 450 IU recombinant epithets combined with 5 IU growth hormones. But after 3 days injections, no response for the from the ovary. So what are we going to do? So we cancel the cycles or revert to other fertility clinics. So for this case, we decided to give the extended clomifene citrate. This is we give the CC 150 milligrams for 9 days. And fortunately, after 9 days giving CC, there was one dominant follicle in the left ovary, and then we succeed retrieve one oocytes. And then we have one 8 cells embryos was frozen at the time on the third of embryo's development. I think the extended clomifene citrate was proposed almost 10 years ago by Badawi. At the time, the extended CC was used in order trying to expand the FSH window in the CC resistant PCOS patients. And then we can see through this table the result of extended CC. Even the endometrial thickness was thinner in the CC group compared to low dose gonadotropin, and also the clinical pregnancy rate is half compared to the gonadotropin group, but they have the same miscarriage rate. So that's why extended CC should be considered, because it is economic, efficacy, and safety advantages, especially in the CC resistant patients. And we can think also to use in the poor responder patients. And then the next month, the patient came again for the second IVF cycles, and we directly give the high dose gonadotropin. So during 9 days stimulation with total dose of recombinant FSH around 4,100 IU, with total dose recombinant LH 450 IU, with supplementation of growth hormone. And fortunately, we were retrieve 5 oocytes at the time, and we do the frozen embryo, fresh embryo transfer. 3 embryos were replaced at the time, and then 2 embryos were frozen. So if you look, this is one of feature of Indonesian Kalkulator of Oocytes. Through this formula was established in 2016 based on 1,600 patient Indonesian patients data. And then for this patient, for example, we can put this is the 38 years old, and then level of AMH 0.01, and then the calculator was recommend the use of starting dose of recombinant FSH. It should be at least around 236 IU. And then for predicting the mature oocyte, if we put the 38 years old, 2 FC and 0.01 AMH, they are predicting that we can retrieve at least 4 mature oocytes. And for this case, we retrieve 5 mature oocytes. So if we compare these 3 patients, this is less than 40 years old with low level of AMH. This is the second patient, more than 40 years old with low level of AMH, and then this is also the 43 years old ladies with normal serum AMH. The question is, who is the poor responder? This is the first patients, patient 2 and number 3, or all the patients. If you look, this is the Bologna criteria in 2011. It is clear that poor responder patients should be fulfilled 2 out of 3 criteria. The first is advanced maternal age, previous poor ovarian response, and abnormal ovarian reserve testings. But if we, based on the Sesungkara studies, I think it's already a lot discussed within today's meetings, that the optimum number of the oocytes during IVF for having the optimal pregnancy is around 15 oocytes. So that's why our main goals in during for control ovarian stimulations, we are trying to get the normal response between 4 to 15, but the optimal one is between 10 to 15 oocytes. More than 16 is hyper responders, and then less than 4 is poor responder, and between 4 to 9 it is classified as a suboptimal responder patients. So Alfiji, I think in 2016 has already classified poor responder as a Poseidon group. Group 1 and group 2, it is the poor ovarian response group, with the group with adequate ovarian reserve, with the FC more than 5 and AMH more than 1.2. But the third group and the fourth group, it is really poor ovarian reserve. So the prognosis of group 1 and group 2 is better than group 3 and group 4. But group 1 is better than group 2 because this is less than 35, and also group 3 is better than group 4. So if we can use this use the high dose gonadotropin, group 2 and group 3 maybe we can consider to give a recombinant LH supplementation, and then group 4 I think is appropriate for dual ovarian stimulation. And another case is case number 2. This is I think Poseidon group 4. Is lady 42 years old with very low AMH level, and they want to go to IVF. And this is we starting with high dose gonadotropin in the first cycles, and then we success to retrieve the 3 oocytes, and 1 embryo was frozen. And we, according to Shanghai criteria, after 5 days after oocyte retrieval, we planning to start luteal phase ovarian stimulations, and then we on the second oocyte retrieval we succeed to retrieve the oocyte, and 1 embryo was frozen. So we have 2 embryos was frozen. So we are coming to the Indonesian calculator of oocyte. It was established 2016 based on the AMH Indonesian Women AMH Normogram that was published in JARS in 2013. So we create this calculator to predict AMH to age. For example, if the women have the serum AMH and put into this calculator, they will know their biological age. And also we can predict the dose of recombinant FSH and the number of mature oocytes during ovarian stimulations. This is, for example, if we have 2 patients, 25 years old on chronological age and different serum AMH, the first lady is 5.4. If we enter to this calculator, it will reveal that biological age is 25. It is really the same with chronological age. But the second patient with very low level of serum AMH, if we enter to this calculator, it will explain that the second lady has the biological age 42 years old. So I think we should do more aggressive treatment on the second ladies. And also for making a prediction of initial dose of recombinant FSH and prediction of the mature oocyte. For example, the lady is 40 years old with serum AMH 1.1 and FC5 follicles. We can put into this calculator the 40 years old with AMH 1.1. They recommend 236.5 recombinant FSH, IU recombinant FSH, and then the number of mature oocyte prediction 40 years old, and then FC is 5, AMH 1.1. So the calculator was predict that this patient maybe can get the 5 mature oocytes. So we are trying to make a validation study on this calculator based on the poor responder groups and normal responder groups. This was the chronological age compared to the biological age. The poor responder one, this is the real data, 37.5 years old, and then the normal responder one is 33 years old. This is the biological age, the age based on serum image. The poor responder has a biological age older than the chronological age, and then the normal responder, they have biological age is younger than the real chronological age. And then the oocyte number, this is the real data. The poor responder, they have a median around 3 to 4 oocytes, and then this based on calculator. The calculator predict that the poor responder group will have around 5 oocytes compared to 4 to the real data. And the normal responder, the calculator predict around 10 oocytes compared to the real data around 13 oocytes. And then how about the initial recombinant FSH? In the poor responder one, the initial recombinant FSH around 270 in the median, compared to the apps they recommend around 230. And then in normal responder, the dosage is lower compared to the prediction from mobile application. So now the study is still ongoing. So we are trying to analyze what is the gap, why there is a gap between the real data and the prediction from the calculator. This is also we are trying to see the androgen level. We know that there is a synergism between FSH and androgens. Whereas the androgen will augment the FSH activities in the receptor, will increasing the gallbladder cells proliferation and augments the aromatase activities in converting androstenedione to estrons. And then through our data, this is in the poor responder 1, in the follicular fluid, we found that significantly higher the level of testosterone in the follicular fluid from poor responder patients. And then it is related to the number of FSH receptor expression on the gallbladder cell of the poor responder patients. So it means that more androgen is needed in the poor responder patient in order to augment FSH receptor expression in the granulata cells. Also, it is supported by the data, the expression, the correlation, the positive correlation between LH receptor in the poor responder patient with the oocyte maturation and also with fertilization rate. It is vice versa in a normal responder one. There's a negative correlation between LH receptor with the oocyte maturation and fertilization rate. So it is explained that in the poor responder they need more androgen in order to increasing the oocyte maturation and also fertilization rate. So how do we treat the poor responder patients? So I think this is, if we have the poor responder patients, it should be classified the less than 35 years old and then more than 35 years old. I think this is with adequate ovarian reserve. It is correspond or appropriate with the Poseidon group 1. And then if they are have inadequate ovarian response, they appropriate with the Poseidon group 3. And this is the more than 35 years old with adequate ovarian reserve. It is correspond with Poseidon group 2. This is the Poseidon group 4. This is the worst prognosis, and the group 1 and then the group 1 and then the group 2 is better prognosis compared to group 3 and the group 4. So when should we do ovarian stimulation in the poor responder patients? The first, of course, we should see whether we can see antral follicle by transvaginal ultrasound. If antral follicle was detected, we can decide to start stimulations. We can use the conventional stimulation by using high dose gonadotropin or supplementation by LH and growth hormone. Or we can also doing random start stimulation and then followed by frozen embryos. And then this one is after oocyte retrieval. Also we can choose the dual stimulation, and then of course the embryo should be frozen. The problem is if there is antral follicle count was not detected, it is very difficult. So the serial ultrasound is quite important, and also precursor androgen or androgen supplementation of or even clomiphene citrate may be useful. And then if the antral follicle count was detected, we can continue to start stimulation conventionally. So I'm coming to my last slide. So as take-home messages, so very important, the initial screening of poor responders should be based on the patient's age and ovarian reserve. And then we have this one, digital mobile application for Indonesian Kalkulator of Oocytes. Now it is useful in predicting initial dose of recombinant FSH and number of oocyte retrieved for Indonesian gynecologists who wants to do control ovarian simulation. And also it is useful for helping the patient knowing their biological age. And then number 3 is ovarian simulation should be in the poor responder should be considered when antral follicle is seen by transvaginal ultrasound. And the last, androgen or precursor androgen supplementation is very important in order to squeeze ovary, releasing the residual follicles in poor responder patients. Thank you very much for your kind attention.